Okay, good evening, everyone. Welcome to the 8th series of the UpperGI virtual grand round. Okay, I think it has been a great success since we started this in March. So till date, we have about 700 registered participants, and every week we have up to more than 200 viewers. So today we're going to talk about something very related to us, especially in Malaysian setting, because most of the gastric cancers patients come in very late stage. So we're going to talk about conversion therapy in patient with metastatic gastric cancer, right? Just a few housekeeping announcements before we start, right? Before that, I'm going to introduce my core host today, Mr. Lim Shyang Yee, who is my dear mentor, and also he's currently the upper GI surgeon practicing in Penang Adventist Hospital. So for the housekeeping rule, again, please utilize the Q&A chat box function because all of you are muted when you enter the webinar chat room. So please feel free to put up your questions and we try to answer as many as we can. And again, just to remind you that the webinar is recorded and the recorded version will be made available after the entire series is over. It will be put on the MUGI's website and e-certificate will be sent to you at the end of the whole series, and you can use that to claim for your CPD point. And of course, please help us to give your feedbacks at the end of each webinar, which is very important to us, right? So without further ado, we would like to introduce Mr. Rama, who is currently the upper GI surgery fellow working in Kuching Hospital. He will talk to us today on conversion therapy for inoperable advanced gastric cancer. Rama, the screen is yours.
Okay, thank you, Mr. Kelvin, for the kind introduction. Okay, the realm of metastatic gastric cancer is undergoing a paradigm shift. Both the West and the East are racing towards individualized treatment strategies and moving away from the old all or none approach. Borders are being crossed now. So with the advancement in chemotherapy, both systemic and local, and immunotherapy with genomic typing, surgery for gastric cancer is becoming more feasible and safe. Thus, the topic today is to discuss current treatment options for advanced gastric cancer. This is a case presented to our center in 2019. MG, a 50-year-old active smoker underlying dyslipidemia, presented to us with an epigastric pain, loss of appetite, loss of weight for more than 10 kilos in 3 months. Clinically, he was malnourished, ECOG 1, and BMI was about 17. OGDS showed an obstructed piloantral mass. CT-TAP staging showed a T4N2M1, and biopsy of the gastric mass showed a moderately differentiated adenocarcinoma. This is the CT imaging done in 2019 during his initial staging, showed an extensive liver lesion with a dilated stomach. And this is the pyloroantral area, which is looks bulky and there is no very close proximity to the liver mass. So what would you do for a patient like this? Please choose your answer. I will give you about a minute. Then we will discuss the answer at the end of my presentation. Okay, so we will continue now. Continue the discussion for advanced gastric cancer. So this is the WHO GloboCan 2018 report, which shows that gastric cancer is the 5th commonest cancer and it's the 3rd leading cause of cancer death in the world. This is the Malaysian National Cancer Registry report 2012 to 2016. It shows that gastric cancer is one of the 10 commonest cancer among the Malaysian male. And this report also shows that half of the patients were diagnosed with stage 4 disease, 30% present at stage 3, 10 to 15% at stage 2, and less than 10% present at the stage 1. So what are the possible explanations for the late presentation? Aggressive systemic disease, early metastasis, vague symptoms, late presentations, lack of awareness between the patient and physicians, and delay in referral for endoscopy. Traditionally, surgery for patients with incurable factors for gastric cancer are either a palliative surgery or a reduction surgery. So palliative surgery is performed for symptomatic patients, patients who have bleeding, who have gastric outlet obstruction, where you can offer a palliative gastrectomy or a bypass gastrojejunectomy. And reduction surgery is defined as gastrectomy performed for patients with unresectable liver metastasis and peritoneal metastasis, while they don't suffer for any tumor-associated symptoms such as bleeding and obstruction. The aim for reduction surgery is to prolong survival and to delay the onset of symptoms by reducing the tumor volume. However, Regatta trial, which is a phase 3 randomized control trial at 44 centers of hospital in Japan, South Korea, and Singapore, looked into the superiority of doing a gastrectomy compared to a standard palliative chemotherapy. It showed that reduction surgery in asymptomatic patients did not provide a survival advantage compared to chemotherapy alone. Furthermore, chemotherapy compliance tend to be better off before gastrectomy, and the increased level of cytokines after surgery makes the proliferation of tumor even faster. So, based on Regatta study, it failed to prove survival benefit of reduction surgery. Therefore, surgeons are strongly advised not to perform this type of surgery anymore. Standard of care is palliative chemotherapy with best supportive care. However, with palliative chemotherapy, the median survival is about 6 to 15 months. So this is a traditional algorithm of management for an advanced gastric cancer. If it is an inoperable or metastatic, you offer them palliative chemotherapy. If the center has immunotherapy, they can be further offered immunotherapy. Options of systemic therapy in metastatic gastric cancer is the first line is systemic chemotherapy, which is platinum and fluoropyrimidine based as the first line. So the example of platinum that is commonly used is cisplatin and oxaliplatin, while fluoropyrimidine 5-fluorouracil and cefacetimin. And single agent cytotoxic chemotherapy such as irinotecan, paclitaxel, and docetaxel are the second line chemotherapies. Okay, so this is a cancer immunity cycle. If you can see, once there's an onset of a cancer and there's a cancer cell death, that cells will be detected by the cancer cell antigen, either by the dendritic cells or the antigen presenting cells, which will activate the T cells. And the T cells will then travel to the cancer site and recognize the cancer cells, and they will start to kill the cancer cells. So this is the cancer immunity cycle. However, in the red are all the possible ways where the natural defense system can fail. So what are the causes? Low mutational burden, reduced antigens, tolerogenic dendritic cell induction, peripheral tolerance induction, and for like gastric cancers which are very highly angiogenic, there's a reduced infiltration and antigen loss, MHC loss, activation of inhibitory immune checkpoint, and immunosuppressive microenvironment like malnourished patient and so on. So based on the cancer immunity cell, targeting the anti-tumor immunity molecules for cancer cell is revolutionizing cancer treatment, and this involves genomic studies. So Cancer Genome Atlas, TCGA, and the Asian Cancer Research Group, ACRG, are the pioneering groups in the genomic studies for gastric cancer. So genomic typing identifies mutated genes coding abnormal proteins, which will be the target of immunotherapy. These subtypes help to classify gastric cancer to specific prognosis, high-risk group, and the suitable choice of immunotherapy. For example, in the TCGA, they have the Epstein-Barr virus positive group, MSI, which is the microsatellite instability, chromosome instable, CIN, and genomic stable. These are the 4 categories. EBV has the best prognosis, while the genomic stable has the poorest prognosis. So these are the drugs that are approved for clinical use based on the personalized medicine, biomarker for personalized medicine. HERS2 amplification, trastuzumab, PD-L1 amplification, pembrolizumab, and MSI high pembrolizumab, and VEGF overexpression, ramucirumab. So this is a proposed biomarker-driven algorithm for targeted in advanced gastric cancer published by Lim in 2019. So the first line treatment, if the patient is HERS2 positive, you can offer them platinum-based regime with a trastuzumab, and second line treatment, if it's MSI high, pembrolizumab, and if it's MSS, ramucirumab with paclitaxel, and third line treatment is if the PD-L1 more than 1%, pembrolizumab. So that was the traditional options of treatment. Now, what's new? Conversion therapy first was reported in 1997 by Nakajima at the Cancer Institute Hospital in Japan. It is defined as surgical treatment aiming at RO resection for originally unresectable or marginally unresectable tumors after remarkably good response to the chemotherapy or radiotherapy. The author, Yoshida, classified conversion therapy into 4 categories based on the incurable factors. The incurable factors are T4B lesions, i.e. locally advanced, infiltrating the pancreas and so on, lymph node metastasis, non-regional, for example, paraiotic, supraclavicular, mediastinal, and hepatic metastasis and peritoneal carcinomatosis. So category 1, which is called potentially resectable metastasis, consists of single liver metastasis, patients with positive peritoneal cytology, patients with a few metastases to the paraiotic lymph nodes limited to 16A2 and 16A2 and 16B1. And patients in this category were treated with surgery, which consists of gastrectomy plus the metastasectomy either before or after chemotherapy. And category 2 is marginally resectable metastasis. These metastases were considered as technically or oncologically unresectable. Therefore, induction chemotherapy will be given, and subsequently, if it's feasible, RO resection is feasible, gastrectomy and metastasectomy will be done. Category 3 and category 4 are patients who present with macroscopic peritoneal dissemination. Okay, this is an algorithm which further simplifies what I have mentioned prior to this. So basically, you have 2 groups. Category 1 and 2 are macroscopically peritoneal dissemination negative. So this group of patients, we will offer them chemotherapy, and if they have an effective either a complete response or a partial response, we will subject them to primary and metastasectomy surgery for the primary and metastasectomy. For the category 3 and 4, these patients have positive macroscopic peritoneal dissemination and with or without involvement of other organs. So these patients ideally are treated initially with molecular targeted therapy plus minus intraperitoneal chemotherapy. If they do have response, i.e. they achieve a complete response or a partial response and they have a negative peritoneal cytology, then these patients can be considered for a volume reduction surgery. Okay, now we look into liver resection for metastatic gastric cancer. So patients who are candidate for liver resection are patients who have primary tumor which we can achieve a RO resection, no peritoneal dissemination or distant lymph node metastasis, complete resection of the liver metastasis possible, and patient is fit for a surgery which involves a liver resection with a primary tumor resection. The 5 year overall survival of multiple studies so far shows about 10 to 40% for patients who are able to achieve a RO resection for the primary tumor and a RO resection for the liver metastasis. Factors that influence prognosis and the overall survival are liver resection margin negative. Serosal involvement of the primary tumor points into a poorer prognosis. And solitary liver lesions, patients with solitary liver lesions do better, and patients without distant lymph node also have a better prognosis and overall survival. These kind of cases are best referred early to subspecialized centers with high volume cases so that the patients can be closely monitored and interventions can be offered immediately. This is a meta-analysis which summarizes that in patients with liver metastasis, those that have single and unilobar has the best prognosis post liver resection. So that is for liver. Now, for patients who present with paraiotic lymph nodes are considered as distant metastasis by the UICC and the Japanese Gastric Cancer Association. And stomach cancer study group of JCOG shows that a 3-year survival of only 5% in patients who undergo paraiotic lymph node dissection with gastrectomy. So what the JCGA recommendation 2018 shows that after a conversion therapy, if the patient is rendered able for resection of the paraiotic lymphadenectomy is weakly recommended for small number of nodal swelling limited to the node station of 16A2 and B1 region, and or swollen lymph nodes that are borderline resectable around the branches of celiac artery. So in summary, after conversion chemotherapy, if patients show partial or complete response, extended gastrectomy can be offered in subgroup of patients with paraiotic lymph nodes. Okay, next we are going to talk about peritoneal metastasis. Synchronous peritoneal carcinomatosis is the most frequent site of metastasis in stage 4 gastric cancer. Peritoneal carcinomatosis occur in about 14 to 43 patients of gastric cancer patients and represents 35% of all synchronous carcinoma. Primary tumors with serosal invasions have a higher risk of peritoneal metastasis. This is a classification to quantify the extent of the peritoneal metastasis burden. So there is a Japanese classification which classifies it into P1, P2, and P3, whereas there's a Sugar-Becker classification used in the West where they have a quadrant of 1 to 8 with a assessment of the small bowel from 9 to 12. So you can have a total peritoneal cancer index of 12 times 3, about maximum 36. Higher PCI score means poorer prognosis. For example, candidates who we offer HIPAC are generally patients with PCI score of less than 7, although some centers can take up to about 10. So what are the treatment options for gastric cancer with peritoneal metastasis? Surgery, gastrectomy, peritonectomy, local chemo, intraperitoneal, hyperthermic intraperitoneal chemo, HIPAC, and pressurized intraperitoneal aerosol chemo, PPAP, and systemic chemotherapy, which consists of 5-FU, S1, cefactabine, cisplatin, oxaliplatin, paclitaxel, docetaxel, irinotecan, ramucirumab, and nivolumab. So these are the options of treatment that is available for patients with peritoneal metastasis. Now, this is a study of 500 patients looking into the recurrence pattern after a neoadjuvant chemotherapy and gastrectomy, which shows that peritoneal metastasis is the commonest and the survival is the poorest. So, based on this study by ICOMA, it shows that prophylactic HIPEC for advanced gastric cancer should be considered, and more studies are needed to look into this so that we can reduce the risk of recurrence from the peritoneum. This is a summary of the intraperitoneal chemotherapy for gastric cancer. So you can see that systemic chemotherapy gives an overall survival of about 15 to 17 months. Catheter-based intraperitoneal chemotherapy of overall survival of about 18 months with systemic chemotherapy. HIPEC and cytoreductive surgery gives an overall survival of about 11 months to about 18.8 months. However, if you can achieve RO resection with a CC of 0, the 5-year survival post HIPEC and CRS can increase up to about 20%. PPAP is something new, and the overall survival based on some of the study goes up to about increase overall survival to about 19 months. The benefits of PPAP is that you can do a repeated dosing, patients have a good quality of life, and yeah. So PPAP stands for pressurized intraperitoneal aerosol chemotherapy, and it is a novel drug delivery system able to induce regression of peritoneal metastasis in the salvage situation. It can be offered as a neoadjuvant. So after offering PPAP, where patient can go repeated dosing, if they have good response, let's say they have complete response or they have partial response, then these patients can be indicated for cytoreductive surgery with HIPEC. In summary, the benefit of intraperitoneal chemotherapy is it has a low rate of systemic toxicity, improved symptoms, and quality of life for patients. This is a study called Phoenix gastric cancer trial done by pioneered by Professor Ishigami. It was published in 2018 to compare combined intraperitoneal and systemic chemotherapy with systemic chemotherapy alone in gastric cancer with peritoneal metastasis. The eligibility for the study are patients with P1 peritoneal metastasis. So the treatment arms are intraperitoneal paclitaxel with systemic S1 and paclitaxel versus S1 with cisplatin. The primary endpoint of the study is to look into overall survival. The primary analysis in the full analysis set failed to show statistical superiority of the intraperitoneal regimen despite a prolongation of the median survival time by 2.5 months and a hazard ratio of 0.72. However, the sensitivity analysis, which took into the account in the imbalance in ascites between the two groups, showed that intraperitoneal paclitaxel is clinically effective for treating gastric cancer with peritoneal metastasis. So based on this study, more studies and results are needed, and we are to see whether intraperitoneal chemotherapy can be brought in as a mainstream treatment for patients with advanced gastric cancer to improve their overall survival and quality of life. The 2018 Chicago Consensus summarizes well the role of conversion surgery. So when a patient with a peritoneal metastasis present to us, we do the staging CT with KIV with PET scan, and then subject the patient for standard chemotherapy. Based on the response to the chemotherapy, we restage them. If the patient has a low peritoneal carcinomatous index, then we can offer the patient conversion surgery with cytoreductive surgery with gastrectomy and intraperitoneal chemotherapy. So after the chemotherapy, if the patient has stable disease with a high peritoneal carcinomatous index, then you can subject, rather than subjecting the patient to surgery, we can still offer them a laparoscopic intraperitoneal chemotherapy or neoadjuvant intraperitoneal and systemic chemotherapy. If the patient responds to NIPS and intraperitoneal chemotherapy, we can then consider for gastrectomy, i.e. cytoreductive surgery for selected patients with good response. Okay, now back to our case. So can we have the polling results? Okay, so I see here that the polling result shows that B is has a 63.7% response. Okay, so so what we did for our patient was he was offered chemotherapy, oxaliplatin plus oral cefactabine. So our patient actually, after the staging, we did a mini laparotomy and did a feeding jejunostomy since he was obstructed rather than doing INET. And subsequently, he completed 12 cycles of Xelox and repeat OGDS noted a normal OGDS. And his post-chemo CT showed a complete response to the primary tumor and a partial response to the liver. So this is the CT scan of his post-chemotherapy. You can see the pylorus appears to be normal, normal looking. The liver looks fairly well. And this is the partial response to the liver. The tumor has shrunken more than 50%. So now, what would you do now for this patient? You can poll. I'll give you about a minute to choose the answer. Then we will discuss what we did for the patient after that. Okay, so looks like 79.8% of the audience out there will refer UpperGI Center for a curative cytoreductive resection. 16.9 chose to start molecular directed therapy. Well, molecular directed therapy can improve the overall survival, but there's a few factors that you have to look into. Number one, in our healthcare system, i.e. in Kementerian Kesihatan, the cost for targeted therapy is expensive, and whether the options of molecular studies is also depends whether is offered or not. So that is one. And continue with second line chemotherapy, it was 3.4%. So anyway, this is what we did for the patient. He underwent a total gastrectomy with a left hemihepatectomy. And this is the specimen of the liver, which shows a segment 2, 3, 4B tumor involving the gallbladder and the remnant of the falciform ligament. This is the specimen of the stomach, which looks fairly well. Okay, now we will discuss the HPE. So, histopathology reporting post-chemotherapy surgery is important because it correlates with the survival of the patient. So there's a few grading systems which are to name some is Mendet, pneumonia, which is the Japanese classification, and Becker. So if you see this box here on the upper left, this shows a HPE with a no residual tumor, and it's followed by a less than 10% residual tumor, and the bottom right is a 10 to 50% residual tumor, and the last one is a more than 50%, no neoplastic regression. So that is a no response to chemotherapy. So this is a different reporting system, post-neoadjuvant. Basically, all the HPE is looking into the degree of tumor infiltration, the fibrosis, and the tumor necrosis. So 30% of gastric cancer patients receiving induction chemotherapy can have complete pathological response. So this is the tumor residual grade from 5 to 1. So they are looking into the fibrosis and the necrosis. So in my patient, we used the mandate reporting. We showed a TRG1. Prepyloric tissue shows focal fibrosis with multiple collection of foamy histiocytic admixed with some lymphocytes. Total lymph nodes seen not involved by tumor, primary tumor margins were clear, and the liver lesion is correspond to the HPE of the pre-palliatic biopsy of the stomach previously. So, in summary, surgery after response to chemotherapy. Rationale for gastrectomy is metastasis can be controlled by systemic and intraperitoneal chemotherapy. Primary tumor is not controlled long-term by chemotherapy because patient can subsequently develop resistance to the chemotherapy. So criteria to proceed to surgery: no unresectable metastasis identified by imaging, disappearance or absence of cancer cell on peritoneal cytology, and laparotomy findings if it is resectable by standard or extended gastrectomy. So some centers can offer, before doing a laparotomy, you can offer a relook laparoscopy assessment to look for macroscopic peritoneal metastasis before you proceed to laparotomy. So in conclusion, advanced gastric cancer is common due to late presentation. Conversion therapy in this group is feasible with improved outcome and survival in subset of patients. MDT and multimodality treatment, including systemic and intraperitoneal chemotherapy and immune-targeted therapy with cytoreductive surgery, are important. Individualized strategy is the key to the future of management in advanced gastric cancer. With that, thank you all for your kind attention.
Okay, thank you very much, Mr. Rama. I think that was a very concise and precise presentation, and in sum up, I mean, the latest treatment strategy for advanced gastric cancer. So, I guess we're going to take a commercial break now. I think we have a short video to be shown by our sponsor today, LabTech. So we'll come back after the video.
Okay, welcome back all the participants for our discussion today. Thank you, LabTech, for the video presentation on their new devices on stapler. And I think we have one participant who would like to know from our presenter, how do you choose which patient to go for staging laparoscopy? Who and when is it necessary to do so? Right, Rama, what do you think?
Okay. From my opinion, if in your system it is feasible, any patients who you suspect have a locally advanced gastric cancer, you can do a lab staging, because during the lab staging you can get sometimes 20 to 30% of patients with very locally advanced or metastatic gastric cancer, they can have peritoneal metastasis macroscopic, which may be missed by the CT scan. So it can give you a important information on peritoneal burden in the abdomen, and you can also do peritoneal cytology so that and assess the ascites and all that before you proceed with surgery for these patients. So, but the problem is sometimes you need a dedicated lab. If you want to look for the cytology, after you put in a camera, you take the fluid, you want to send for cytology, you can't wait. Sometimes they don't have a lab which can report for you the report immediately. So those are the limitations. So if you're sent, I mean, yeah, that's my opinion. Lab staging is beneficial if to assess the burden of disease before you proceed with any laparotomy and extensive surgery.
So in your case, your case presentation, you have liver metastasis diagnosed on CT scan, but how would you know whether this patient have a two other second factors like peritoneal disease?
That's why it's either if you, number one is we can do it with lab staging. Number two is whether if you did a PET scan for this patient, then maybe PET scan can pick up peritoneal mets.
All right. So basically, if your CT says is marginally resectable, you may want to do a lab staging.
Yes.
Because
yes.
I think CT is clear cut, you may not do, right?
Yeah. Yeah.
I guess by and large, staging laparoscopy is the standard of care for us when we do a gastric cancer surgery. I mean, ranging from maybe T2 to T3 tumor, especially. So because we know that conventional CT and PET scan, they may miss up to 20% of lesions, either in the peritoneum or in the liver. And so the advantage of doing a staging laparoscopy, of course, we can spare patient from a laparotomy. And if let's say during a staging laparoscopy, we notice very bulky method lymph nodes or any non-regional lymph nodes, or maybe patient have a liver or peritoneal nodules, then we can actually still back off and spare them from a laparotomy, and we can shorten the time from recovery. Instead, we send them for a systemic chemotherapy first. So I guess in Malaysia, all of the upper GI center, we practice a staging laparoscopy as a standard. Of course, in East Asia as well, it is a standard practice, just that some of the countries, they prefer to do it staging laparoscopy as a single surgery. But in Malaysia, we don't have the luxury of OT time. So we usually do it in the same setting as the planned curative intense surgery. So on staging laparoscopy, for example, if there's no gross peritoneal disease or metastasis, then we will proceed with a curative surgery, either a laparoscopic gastrectomy or an open gastrectomy. And of course, we send the peritoneal fluid for cytology routinely. It helps us in the final staging of the cancer. But of course, we don't have the luxury of doing frozen section. So we will just proceed for the curative intent treatment if, let's say, there's no gross peritoneal disease. Or what do you think, Mr. Lim?
Yeah, I think this is how we generally practice in Malaysia.
Yeah.
Sometimes we should do it routinely. It's a lot. My anesthetists will get confused. Sometimes I book for staging lab. Sometimes I don't book for staging lab.
Yeah.
How you decide. So I tell them, if I think that patient require some surgery, laparotomy, for example, obstructed, or the bleeding, regardless of the peritoneal disease, we need to do something for the patient. I'll tell them, I will not do staging laparoscopy. You know that it's obstructed. You need to somehow do a palliative bypass. I will give you benefit of doubt. I do a laparotomy. If by chance no peritoneal disease, I go ahead and resect it. If there's too extensive, I'll do a bypass. But of those who are no much of symptoms, no obstruction, no bleeding, I will still routinely do a laparoscopy examination.
Yeah, I totally agree with that. Yeah. So we move on to the next questions. This is regarding the phenotype variations of gastric cancer. I guess one of the participants would know that, is it routinely being reported by the pathologist, or it is something that we have to request for it? What do you think, Mr. Rama?
In our country, we as far as I know, that we don't do genetic studies for gastric cancer per se. It is more on I mean the slide I showed just now, the Genomics Atlas Center, and in Japan they do it . So we don't do genomic studies here.
It's something that we have to request because you need extra immunohistochemistry staining, and of course, cost is an issue. So it is of course helpful in patients, especially those in patients with advanced gastric cancer. You want to know that whether they are genomically stable type or unstable type, because for the unstable type, probably they have this P53 mutation and they are more sensitive to HER2 receptor blockers such as trastuzumab. And those with MSI high, probably they are more towards targeted therapy treatment. So it's something that we have to request if, let's say, we think that this will help the patients, probably. But at the moment, probably it's more for a private practice setting, and also for patients that we plan to enroll them in a targeted therapy trial. Right? So Lim, what do you think?
Yeah, I think for practical wise, if all those targeted therapy and immunotherapy is widely available, then there's a role of doing requesting pathologists to do these phenotype studies. But I think since we don't have any available as a targeted therapy, as a treatment line for us, it may not be clinically useful. But again, based on TOGA trial, the role of HER2 receptors is very important. I think we see quite a number of patients who are HER2 positive. You add in the Herceptin to the standard chemotherapy, they have quite a good response, and they can go for conversion therapy. So for now, I think HER2 is widely available in our setting because HER2 is done for breast as well. And the other one is targeted is PD-L1. Whether PD-L1 again, the immunotherapy is not widely available. Then PD-L role may be very limited for practice now. So we go to the next question, sir. Another participant would like to know, any role in palliative gastrectomy for patients presented with bleeding and peritoneal disease, right? This is one part of the question, sir.
Sorry, the question, any role of palliative gastrectomy patient presented
with bleeding and peritoneal disease?
If the patient has a bleeding, then you have to yes, there is a role. There is a role for gastrectomy, palliative gastrectomy, if the patient has bleeding lah, because it's life saving, and but that will be just a reduction surgery, and it may not improve the patient's overall survival.
Right. Yeah, I think the regatta trial you mentioned earlier in the slides did mention that there is a benefit for those who are symptomatic, example, obstructed, or those who are bleeding, right?
Yeah.
Kevin, anything to add?
Yeah, I think I agree with Rama and Muslim. I mean, for patients, although they come in with metastatic disease, if they are obstructed or they are bleeding, of course, not only about the disease factor, we have to assess the patient's factor. If patient is fit, good ECOG status, and we foresee that they may live a bit longer, probably we should still consider a palliative resection. Of course, for obstruction, we can consider stenting in some instances. And bleeding-wise, I don't think hemostatic radiotherapy is really helpful. Probably those with significant bleeding, resection is better in terms of their quality of life, right? And okay, we have another question. It's about the recent checkmate 557 trial. So we actually will be seeing more patients going for adjuvant nivolumab post-esophageal gastric cancer surgery as first line rather than third line. What is your thought on that, Rama?
I
on the
think
checkmate trial?
because these are all targeted therapies, at the moment now it's not widely available in our system. So even in the recommendation by the guideline, it goes nivolumab comes as a third line lah. So I think it still remains and it's under the jurisdiction of the oncologists. So it's best that I mean, we have to work with them, and I don't think it's going to be that easily accessible because of the cost.
Yep. But I guess the recent checkmate 577 trial, the result is actually very, very promising because the survival actually almost double comparing to the placebo group. So again, targeted therapy, I would say they have really great potential and they have a very, very bright future. Who knows, they may actually replace a surgeon in future one day. Probably patient doesn't need surgery anymore. They have a good response with targeted therapy. But at the moment, we are still waiting more and more trials and their results. And of course, things that we have to look into, especially for a healthcare system like in Malaysia, is about cost issue. So again, targeted therapy is not widely available, especially in the government setting. And even in the private sector practice, I don't think many patients can afford that. So although it may be helpful, but we still need further results. And also we need to take into the economics of the treatments. Yeah, that is my thought. What do you think, Mr. Lim?
Yeah, I think all this targeted therapy all started with a look into lung CA and also the role in the RCC, renal cell carcinoma. These are two cancer that usually started with very promising results historically, and now even as a first line for non-resectable lung CA, it uses immunotherapy as a first line. So they have achieved a good result with this immunotherapy, but for gastric CA, this checkmate result may seem promising, but I think we need to look into sub-analysis before we can accept it as a first line, because first thing, cost is an issue, and this is no ending. Perhaps you have to go on for life. This treatment, we don't know when. The moment you stop, I think the disease will come back.
Yeah,
so it's not something that you, unless you can really afford your whole life and carry on with it.
Yep.
There is limitations also with immunotherapy for long term. They can develop resistance and the side effects of the medicine.
Yeah. So we don't know how long enough, whether if you give long, we develop resistance, right? Just like the Gleevec that we use, we know that in Gleevec you use prolonged more than 2 years, right? There's most of them develop resistance, then you up the dose or you go to the second line, things like that. So same thing, all this targeted therapy, we need to follow up the long term to see how effective is it for long-term use.
Have any other questions, Ms. Ling? So we have another question actually on the role of PET scan. Okay, do you think a PET scan should be a routine assessment after, say, you subject a patient for systemic chemotherapy before considering a conversion surgery? What is your thought on that?
So as we saw just now in the Chicago Consensus 2018, PET scan is actually recommended as one of the PET CT is recommended as one of the investigations to supplement the CT scan because these are surgeries with high morbidity and mortality. So PET scan will be able to assess the burden of the disease better, and we can offer a more informed decision to the patient with a PET scan. So ideally if you can perform a PET scan, it will be good. But once again, finance and logistic issues, patients to get the appointment for PET scan in our system, and the cost if they want to do it in private. Yeah, so we have to weigh both of these and then decide.
I guess PET scan, if it's available, it is good to do, but we must always remember that there's also a downfall with PET scan, especially in patients with poorly differentiated carcinoma. The pickup rate may not be accurate, and also with a small lesions, distant lesion that is less than 1 cm, again, that may be up to 20 to 30% of lesion that may be missed on PET scan. So that's why CT is a must, of course, for us to assess the resectability and also distant metastasis. PET scan is good to have, and staging laparoscopy, again, is something that we should do before embarking onto a major surgery for the patient as part of the conversion therapy.
Yeah, I think Kelvin is right. Signet ring carcinoma, with the signet ring, majority of them do not have any uptake on PET scan. So when you do order a PET scan, you must understand that although it's negative, it doesn't mean negative depends on the type of just a signet cell with poorly uptake, right? So perhaps I think in terms of PET scan, we need to complement PET scan with the CT, not only PET alone. PET, a lot of times, sometimes we do PET as separate and CT as separate. You can combine PET with IV contrast. There will be better chance for her to see in a more holistic picture where is the lymph node status and the metastasis. A lot of time we think that we can do a D2 and do clearance, but when you go back to radiologists, ask them to look properly, the paraiotic lymph nodes are often missed out because they don't aware how important is paraiotic lymph nodes to upper GI surgeons like us, because it make a difference whether you need to go for any new adjuvant treatment or not.
Yep. And there's another question actually about the significance of peritoneal cytology, right? What is your thought on patient with a positive peritoneal cytology that actually show metastatic cancer cell?
Okay, if peritoneal cytology, the staging of the patient changes, now it's M1. So the prognosis changes and the overall survival is all affected. So that is the significance of the peritoneal cytology. But since we can't do a frozen section intra-op, let's say if you do a lab staging and you take the cytology, you see the tumor is quite resectable and it's mobile, not bulky. There's no paraiotic nodes and all. You want to go in for a resection, you can take a cytology. It will help you post-op to review the cytology, and if it's positive, then it shows that this patient is a M1 disease. So you can probably discuss with the oncologist to maybe whether they want to offer more aggressive chemo, second line, first line. Yeah.
So the significance of peritoneal cytology here, it is based on two settings. Okay, number one is either when we only do staging laparoscopy alone and we send the fluid for peritoneal cytology without embarking to a curative surgery. So if let's say we only do that in a single setting and the cytology come back as positive, we have to treat this patient as having a peritoneal metastasis. Then we should do something like what Mr. Rama has presented. We should subject patient probably for systemic plus minus intraperitoneal chemotherapy, right? Then we reassess again with a CT, PET, and also again a staging laparoscopy to confirm there is no more, there's a negative cytology, then only we embark on conversion surgery, right? The second setting would be what we are doing now in most of the center in Malaysia. We do staging laparoscopy and curative surgery in the same setting. The peritoneal cytology will give us a more accurate staging for the patient at the end, and also for us to plan for the adjuvant therapy. Okay, there are a few more questions flowing in. Ms. Lim, probably you want to take the next one on the,
Right. Okay, so next question, I think the criteria patients suitable for conversion therapy, so we can appropriately to UpperGI S8. Maybe Rama, you want to summarize?
So the summary of my whole talk is that basically stage 4 disease is not a death sentence anymore. So if the patient has good ECOG function, good functional status, and the disease burden, let's say the liver is a solitary lesion and there is no peritoneal metastasis based on your staging, you can refer these patients to us so that we can appropriately start the chemo. We can even offer them selected good prognosis patients with targeted therapies, and then after that we reassess them. If the conversions, if they have a complete response or a partial response, we can offer them RO resection of gastrectomy with D2 plus with the plus minus of the metastasis also. Yeah. So the criteria is based on the patient factor and the disease factor. Patient factor, their fitness, age, and their comorbids, and the disease is if it is potential resectable with after chemotherapy.
All right.
Okay. All right. Okay. I think we still have 1 minute. Probably I'll just take the one last question. This is regarding the decision on subtotal versus a total gastrectomy. Right. So, how do you decide between subtotal and total gastrectomy, and decision on D1, D2, and D3 lymphadenectomy?
Okay. So, about the gastrectomy, basically, you need to see the tumor. Of course, you will do a scope, and then you see the CT scan. If it is involving the antrum and the HPE is poorly differentiated with a diffuse type, and then based on the HPE, based on the endoscope, you probably want to offer a total gastrectomy for the patient. But if it's a distal tumor and the antrum is clear, and you think you can get a good clear margin more than 10 cm, then I would go for a subtotal for this patient. And the standard practice now is for D2 lymphadenectomy. Studies have shown that D3 involving the paraiotic lymph node dissection does not change the overall survival of the patient.
Okay,
Kelvin?
all right. Thank you. I think that is the standard now. D2 is a minimum, right? And total and distal gastrectomy we decide based on the lesion, and also based on whether it's T1, T2, or T3 lesions, right? So just to sum things up, okay, I think we have answered most of the questions. Those that we are unable to answer, we'll try to answer it online. Again, in summary, I guess gastric cancer metastasis, basically, we divide them into solid organ, liver, or lung. Non-regional lymph nodes such as paraiotic or maybe supraclavicular lymph node or mediastinal lymph nodes. And the other group, which is most common, will be those with peritoneal metastasis, either Gross disease or peritoneal cytology positive. And again, just to remind all the audience here, patient with gastric cancer with metastasis with the above scenario that I have mentioned doesn't mean that we only send them for palliative treatment, right? So there's something about conversion therapy now, and there's more and more study coming out about intraperitoneal chemotherapy, which is very promising, and the targeted therapy is certainly more and more promising as well. There are many trials being conducted in the country at the moment. So if you have such patient with good ECOG status, please do refer to us. Then we can work with the oncologists to probably enroll them into trial. At least we are giving some hope to them, okay? And finally, just to remind everyone, we have our last series for the entire UpperGI virtual grand round next week on the 30th of April, Friday at 8:30 p.m. same time. And the topic will be single vessel conduit necrosis, okay? Who's at fault? And the presenter will be Dr. Sujin Kim, and the moderators are the two big guns in the country, Mr. Supri and Professor Nick Kosai. So we'll see you next week. Mr. Lim, you have any
Yeah, I think
before we go?
so conversion surgery or therapy is something that we should look into it, and do refer to UpperGI Center. Do not just simply brush them off. Right? Okay, Rama. I think Rama have done a good job. Is able to give her an overview. And next week, I think don't miss the last session. We have two very seniors UpperGI surgeons and a trainer, Mr. Shukri, and also Professor Nikosai. They are in the Klang Valley. They were going to talk to us about single vessel necrosis or conduit, right? So Kelvin, back to you.
All right. Okay. I guess that's all for tonight. Thank you for joining. See you all next week. And please fill up the feedback form. And if you have any questions about LabTech device, please feel free to email us as well. Thank you and good night.
Right. Good night.
Okay. Thank you. Thank you.